the environment that physicians work in today is significantly more complex. Some in good ways. We have better diagnostic tools. We have more pharmaceutical options to treat and cure diseases that we didn't have. But at the same time, there's also a lot of other things that make patient care more complex than it has been in the past.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. I have on today's show a unique guest, Dr. Cliff Knight. Dr. Knight is the Assistant Dean of Graduate Medical Education at the Tom and Julie Wood College of Osteopathic Medicine at Marian University. So that School of Medicine or College of Osteopathic Medicine is in Indianapolis, in Indiana. And prior to his current role, working closely with graduate medical education, he was a senior vice president for education at the American Academy of Family Physicians, where he worked relentlessly and tirelessly for physician well-being. Just prior to us beginning to record this episode, we were having a discussion on how passionately he feels that optimization of our workday or optimization of our places of work, sort of operational efficiency, for lack of a better word, and he can correct me if I'm wrong, is closely tied to the concept of physician well-being. So we thought that for the audience of Parallax, because we've intersected, these topics for our listenership, that Dr. Knight would be a perfect candidate and a perfect guest to talk to us about this topic. So without much further ado and with that introduction, Dr. Knight, welcome on the show, and thank you so much for doing this for us. Welcome to Parallax.
Oh, well, thank you. It's great to be here, and I appreciate you reaching out and asking me to have this conversation with you.
Absolutely. So we're going to start by asking you as to what really got you interested. I know there has been now for at least a decade now in the medical literature, I think across the spectrum of all specialties, all broad specialties, including family medicine, I'm sure, the concept of burnout. So my question to you is what got you interested into the topic of physician well-being when you were in your role as Senior Vice President for Education for the American Academy of Family Physicians?
Yeah. Well, thanks. And it actually goes back further than that. So a little bit about my background. I'm a family medicine physician, and early in my career, I became involved in family medicine residency education and served as clinic director and faculty in our family medicine residency, where I had trained here in Indianapolis at Community Health Network. And then I was residency program director for several years. And, when you're in a residency setting, you get to know the faculty very, very well. You get to know your residents very well, and you're able to keep track of how things are going. And so, we would recognize that there were times when our residents or faculty were, having a tough time. Either they had a personal relationship issue that was impacting them, or sometimes in family medicine, we work across the spectrum of ages and all sorts of settings. But for example, if a resident had been involved in a delivery and there was a bad outcome, and we knew that had happened, and so we would sort of check in on that resident. How are you doing? Go through, discuss that. And so I felt like there was a pretty good safety net for the residents and faculty. And then I transitioned into a leadership role where I became chief medical officer across several hospitals. We had about 2,200 physicians across the medical staffs of those hospitals. And right away, what I noticed was we didn't have anything in place as a safety net at that point related to helping those physicians who were struggling either with the tragedies that they've been part of, and they were, experiencing the trauma that their patients had experienced, or they were having personal issues. And so, one of the things I recognized right away, because I was responsible for improving quality of care, patient safety, patient satisfaction, those sorts of things. That you've got to have a medical staff who feel really at the top of their game, and we at that point, there really wasn't much talk about physician burnout. I think the emphasis at that point was on disruptive behavior, and there was a lot of talk about, why do physicians exhibit these disruptive behaviors, and sort of putting the blame on the physicians. And what I quickly recognized was, these are systemic issues that impact physicians in their day-to-day work. Because I think everybody gets up in the morning wanting to do a great job, wanting to do the things they went into medicine to do, right? To serve patients, to improve patients' lives and outcomes. But unfortunately, there's a lot of things in the physician work environment, in the healthcare clinical environment, that impede our ability to have, sort of that meaningful work, because there's a lot of inefficiencies, or things like that. So that's really when it became obvious to me that we had a problem, was witnessing physicians who were struggling. And the culture has been that, physicians are sort of seen to be superheroes. And so, and they make a lot of money. So why do they need support? Why do they need help in these situations? Because, they're smart. They've already proven themselves in medical school and in training and everything. So, why can't they just take care of themselves? And so I think there was a lot of misunderstanding about that. And so then when I went to work for the American Academy of Family Physicians in about 2014, our CEO said, one of the issues that we're seeing nationally that impact our members is a higher rate of burnout in family medicine than in some other specialties. And that's about the time the Mayo was really starting to do their regular burnout studies. And we recognized that, approximately half of all physicians were experiencing symptoms of burnout. And so, it was about 2014, 2015 that I was asked to try and identify ways that we could assist our members and family physicians across the country with improving well-being. And so that's how I got involved in that, was really to try and make sure that we're doing the best we can for our patients through quality and safety, by making sure that physicians are able to practice at their best.
Thank you for going over the genesis of your involvement in this particular topic. I'm going to ask you a question, and that has come up in conversations I've had recently with some of my senior colleagues, perhaps your counterparts, or your peers, because I would still consider myself a millennial, like a senior millennial, and then there's the Gen Z, and then the generation ahead of us. And I don't want to sound as insensitive to any feedback. I'm just trying to be open and have a good conversation about this topic. But the generation ahead of us, their perception or their opinion is that burnout, that the millennial generation, or the millennial physician generation, is like burnt out. Like that has become, like it's become sort of one of the defining adjectives for the generation of physicians that belong to my generation, is what the generation ahead of us feels. When, because like when and some of the commentary is like, oh, when we were in our like mid 40s through 50s, which is when you are trying to do, like, you've young kids in school, you're sort of getting to a point where you're at the peak of your expertise or your skill or your craft, and you want to see as many patients as you want to see. You want to get busy clinically. And so, like, this is like the golden age for doctors, like your 40s and your 50s. And then, we've sort of gone through this, gone through these couple decades, and we never, quote unquote, felt burnt out. Um, and, I think I've sort of listened to what they had to say, and I've been open about it. And I've sort of questioned as to whether this is truly a genesis of art. Like, this topic has come up because of how our generation was trained, or how our generation was born, bred, and raised. And also, I mean, you have to. It's sort of comparisons is not something which I personally like, because you just have different. You have there are so many other factors at play in the ecosystem, which are constantly evolving, shifting, and changing as well, so that it really is not a level playing field when you're comparing two generations across the spectrum of decades. Um, the influx of EMRs wasn't there when probably a generation ahead of us was at the peak of their clinical, uh, practice in terms of, seeing the volume that they were seeing of patients. So I'm going to stop here and maybe, get your feedback or your insight on this.
Yeah. I think this is fascinating, and I think it really gets to some of the root cause here as we try and figure this out. And you do have to understand the causation before you can truly come up with, well, what are the answers, and that's got to be the goal, right? Is try and figure out how we make things better. But it, you know, in short, I have to think things are so much more complex in general now than they were. When I finished medical school, I finished medical school in '87, finished residency in 1990. When I went into practice, the burden of documentation was relatively minimal, and that was right before E&M codes were introduced in the mid '90s. And for me, when I look at within my career, what were some of the watershed moments that made things more complex? I think when we went from being able to just call a visit a short visit, a medium visit, or a long visit, and have to start doing the E&M coding with all of the different elements, that added a level of complexity to my day that was very dissatisfying. It didn't feel like it added any value to the care I provided for my patients, and it slowed me down to where I had to cut back on some of the volume to see patients, because I now I was spending time with E&M coding and things like that I didn't have to do prior to that. So that was one watershed moment. And then another was, the introduction of the electronic health record, which unfortunately just magnified that documentation burden that the E&M codes created when that was introduced. And so, you like to think that the electronic health record is a tool to help us provide better care for patients. And you can't argue with a few aspects of that. Accessibility, being able to remotely access medical records is now a given, whereas it used to be you had to have the physical chart. Legibility, wonderful. It's much more legible now. However, electronic health records were not developed with the clinical aspects truly as the priority. It seemed, at least from the outside, as somebody using them, not developing them, that they had been developed specifically to capture the things that we needed from a coding and billing standpoint rather than from a clinical care standpoint. And so, it didn't feel like the EMR was an effective tool. And a definition of a tool is something that you utilize to help you do work more efficiently, right? You can dig a hole with your hands, but if you got a shovel, you can do it a lot more efficiently. And the EMR never felt like it was helping with a lot of efficiency, at least early on. So let's flash forward now and where we're at. And when we talk with physicians, the feeling that their time is not valued because of being pulled into all of the documentation and the regulatory aspects of things that don't feel like they add value to the care of patients. And all the complexities of communication devices that that frankly I didn't have to deal with in the early part of my career that now are just a part of the environment. And so to sort of look at the generation of physicians now that are in the midst of that, and I see this with our medical students here where I teach, is the constant barrage of communication throughout the day, through every through all the different devices and things. That, along with the complexities of billing, coding, documentation, meeting all the regulatory compliance issues. I just think it's a much more complex environment to practice in now than it was for the generations of physicians that I'm a baby boomer and the generation before me that we had to navigate through. So, I'm an optimist. I always like to look at the positive aspects of things, and I do feel like we're on the verge of being able to access some tools that really will be tools through some people like to use the term artificial intelligence, others say augmented intelligence, whatever you think AI stands for. I've talked to physicians who have been able to utilize AI effectively to improve the documentation workflow, and they feel like it's given them time back in their lives. I'm hopeful that we're on the verge of widespread utilization of AI to offset some of those complexities. But that's what I see is that the environment that physicians work in today is significantly more complex. And again, in some in good ways, we have better diagnostic tools. We have more pharmaceutical options to treat and cure diseases that we didn't have. But at the same time, there's also a lot of other things that make patient care more complex than it has been in the past.
Yes, and in addition to some of the factors that you eloquently listed, I think there's also our the patient subsets that we treat or we see in clinics have also become very complex, and that goes hand in hand with the advances in care, which have led to increased life expectancy. I mean, I see this in cardiology all the time. We have more toys and we have more tools, and we have more devices to keep patients alive. And I think if you sort of then were to map out and parallel some of the advances that have happened in other subspecialties within, broadly within medicine, then there is so much expertise now. Like there is so much content expertise. I mean, even within interventional cardiology, which is a subspecialty of medicine, like you train for 3 years to be an internal medicine physician, then you train for 3 years to be a general cardiologist, and then you train for maybe 1 to 2 more years to be an interventionalist. And even within interventional cardiology, you have expertise, which is like topics and content. So there's so much subspecialization that has added to the complexity. Now you also have a system which is becoming more complex in terms of how the patients interface with the healthcare system and how healthcare providers interface with the healthcare system. And then you obviously have the regulatory changes and certainly how healthcare is funded is a whole different topic of discussion. How do you think all of these factors tie into physician wellness? I mean, that is sort of a niche and your area of expertise here. So how do you think what I just described as a very complex ecosystem in which we want to thrive, or at least in which we find ourselves and we practice medicine, how does that impact physician wellness according to you?
Yeah, you touched on exactly how I like to approach this when I talk with physician groups about trying to find ways to improve professional satisfaction and wellness and well-being. And you use the term ecosystem. That's exactly the term I use. And I talk about 5 levels in the ecosystem. One is that big system level, right? And that one feels hard to have any impact on because it's state regulations, it's Medicare guidelines and regulations, it's who's making decisions when they build EMRs. It's the big system, the big sort of national healthcare system, and then you come down to the next level, and that's the organization that you're part of. And if you're working for a health system or a larger group, there are things specific to that organization that impact the wellness of the physicians practicing there. And again, it's trying to find ways to make sure that there aren't unnecessary regulations that are developed within the organization that impact efficiency the wrong way. And are the values that the organization that you're part of, do those values mesh with your personal values? If you went into medicine really with a focus on, I'm here to serve patients and families and communities, but the organization that you're part of has financial achievement as the number one priority, that can really impact your sense of wellness and a little bit of a moral conflict there of, well, I want to do what's right for the patient, but the organization I'm part of tells me I got to do these things from a financial standpoint. So that's the second level. You got the system, then the organization, then the practice level. That I always describe that. That's where, as a physician, you are putting your hands on patients. That's the team that you work with. So it can be in the ambulatory setting, it can be in an OR, it can be in the cath lab, it can be in the emergency department, wherever your team is that you're part of. There are things in that local ecosystem that impact your wellness. And is it a group you like to be with every day? Do you work efficiently as a team? Do you have the right tools that you need to be able to do your work? So it's that practice level. And then there's our own individual habits and behaviors that impact our personal wellness as well as our professional wellness. How we choose to act and behave, what are our habits, and how does that impact our own well-being, but also how does that impact the well-being of those around us in our personal lives and in our professional lives, the teams we're part of, our families. So that's an important part of the ecosystem. And then the harder one to really ever describe, that kind of puts a coating over all of this, is the physician culture around wellness. And you sort of touched on this when you talked about generational aspects, but it's, what are the expectations of us as physicians, expectations of sort of each other, as far as, are we going to support each other, or are we going to bond together to have a peer-to-peer culture that is understanding, forgiving, supporting, or are we going to fall back on what I would call sort of the old school mentality of suck it up, self-sacrifice is more important than self-care. And if you're not strong enough to be a physician, you need to do something else. I think that there are holdover remnants of that culture. And so, are we setting up the culture in a way that truly does help us find ways to help each other in our wellness journeys and in our day-to-day work that we do. And that's a harder one, again, to define, as well as sometimes it's harder to get people to really think of, well, how would the physician culture be better from the standpoint of helping support ourselves as well as our peers with our wellness? Because, when our patients are trusting that physician the patient's assuming that the physician's doing everything they can to optimize their wellness in order to be able to focus on that patient at that moment. And I'm not sure our physician culture always lends itself for that. So yeah, so those are the 5 areas of the physician ecosystem, and each of those have factors. So yeah, this is a multifactorial. And when I've worked with physician groups about, where do you want to make a change, part of it is having that group discuss, well, where are the issues that are negatively impacting our well-being? Is it at the practice level? Is it our culture is not supportive? Is it the organization we're part of? Their values don't mesh with our values, or their priorities don't mesh with ours? And where would you make those changes that would not make things perfect, because we're never going to get to perfect, but what can you do to make things 10% better, 20% better over the next few months or the next year, so that a year from now, the physician well-being in your setting, including your own, is better, and there's a higher level of professional satisfaction and true sort of fulfillment in what you're doing. And it's hard because there's so much, but you got to sort of prioritize where do you put your efforts to make things better.
Yes, fascinating how you describe the ecosystem there. So thank you for sort of shepherding us through that thought process. In the work that you've done in the space, through the American Academy of Family Physicians, and I don't know how much of that overlaps with your existing role as assistant dean for graduate medical education, but I'm assuming that you've garnered experiences and you've learned enough on the topic. I mean, clearly it's important. I mean, it's all over the medical literature. It's impacting our colleagues. I mean, colleagues have sort of shifted paths, in their careers, and sort of gone on to take on non-clinical roles because of the ecosystem that has now come into existence, in the medical systems we work for. Where do you see is the maximum impact? And if you can share with us perhaps some of the interventions that you've either designed, devised, or been a part of, where you've been able to capture longitudinal data that, okay, this is an intervention, or this is a mechanism, or this is, a change in behavior, or a change in culture, or a systematic reset or a reboot of a system where this has positively impacted, physician burnout or the perception of it.
Yeah. Um, let me focus on maybe 2 or 3 sort of examples there. First of all, I think that you have to be honest with yourself about what gives you the greatest satisfaction in what you're doing, and then try and figure out how you maximize being able to do the activities that bring you the greatest joy, and then address what are the barriers to being able to achieve that. And so, so then part of that then is engaging in at your practice level and within your organization to not complain, because complaints get shut out pretty quick, but to step forward with suggestions on how can we do this so that our patients are better served, so that our teams are able to be more effective and perhaps enjoy more what they're doing, and then the physicians that are involved in that, how do they come out of that feeling more fulfilled? And again, that really is, I think, very locally specific. And so when I've led workshops on this, the first thing I try and do is tell people I don't have the answer that's going to work for everybody. But here's the process. Really look at what it is that is most distressing to you, about the things that come up in your day-to-day practice, and how would you go about improving those things? How would you go about influencing those that actually have the resources to make that better? And sometimes that's a change in practice environment. Sometimes it's just, some physicians just find that they've made the wrong practice decision and they need to find a different setting, a different practice. Some of the happiest physicians I know are ones that decided to open their own practice. They realized that, they may not make as much money, but they have more autonomy and more control, and that means more to them than the financial rewards of being in a larger organization. And so, I mean, part of that is defining your own priorities and determining how you want to approach that. So that's sort of one aspect. Another, though, that I think is so important is being in an organization where leadership recognizes the importance of physician well-being and makes it a priority. Because again, as I've sort of tried to figure out, what is it that when I talk to physicians and I talk to them about how satisfied they are or fulfilled they feel, and especially the ones that are really happy with what they're doing and look forward to what they're doing every day, it usually is a combination of the meaningfulness of their interaction with their patients and feeling supported by the leadership of the organization that they're in. And so I think that's another one. If you, what I've seen is that, feeling valued and respected is so important to physicians, because physicians have sacrificed, have worked hard, have made it through, a lot of milestones to get to where they're at, and they do expect some recognition of their expertise and respect for what they're doing and the importance of the work they're doing. And unfortunately, what I've seen is when physicians don't feel respected by the organizations they're part of, then the fallback is, okay, if you're not going to respect me, then you're going to have to pay me more, because now, instead of doing this because it's something I enjoy and I'm called to do and feel respected, I'm doing it now. I'm doing it for the money, and and that's I always feel bad when I talk to a physician who said, well, if I could just make 10 or 20% more, I'd be happy and everything would be fine. Well, no, there's something else that's missing there. Being respected in the organization you are in and feeling valued is a really important part of this. So leadership in organizations really is, I think, sometimes underappreciated. So those are just a couple of thoughts on that.
Yes, no, excellent thoughts there. I'm probably going to go out on a limb and ask you this. In your experience and expertise, have you come across leadership in health systems where, as much as the focus is, and I'm not saying that one is less important than the other. I mean, clearly that I understand that we need to keep the lights on. Are there health systems and organizations where physician well-being is considered crucial for the existence of the health system?
I think so. So I'm not going to pretend that I'm personally interacting with a lot of different health systems at this point, because I'm not. My focus on a day-to-day basis is helping our medical students move through their journey and successfully get into residency and choose a career path that they're going to be happy with. However, I know there's a lot of effort right now, so I'd really like to highlight what the AMA is trying to do, and it's they're just a few years into this, but I think it's along the right lines, and that is they're trying to recognize those organizations that are adopting best practices to try and improve the wellness of the physicians in their organizations. So the AMA has their Joy in Medicine program, where hospitals and health systems can sort of deliberately apply for recognition at the bronze, silver, gold level of being able to show that they're implementing things to try and improve physician well-being. The sad, I don't know right now who's the gold standard out there as far as actually achieving this. Um, but you can go to the AMA website and you can see the list of the hospitals and health systems that have achieved these levels. And again, this is a relatively new program over the last few years, and so there's a lot of work to be done. But that's I think an admirable goal is to try and identify, okay, which organizations are doing the best job with this. What have they done? What can we learn, and what can be spread from one organization to the next? And so, I really give the AMA a lot of credit for the work that they've done to try and do that, spread best practices, and incentivize organizations to make this a priority. And really, that's consistent with the National Academy of Sciences released a report. Unfortunately, timing wise, it was right before the pandemic. So this was at the end of 2019, where they released a fairly lengthy list of best practices to try and implement. And again, I think it got sort of overshadowed, but it's still a great document out there. You can get it through the National Academy of Medicine. You can download it for free, but it goes through multiple recommendations on what organizations can do to try and prioritize and improve the environment for not just physicians, but for all clinicians, and improve clinician well-being. So yeah, there's some things out there, but again, it really starts at the top level. You've got to have a CEO, a C-suite, board of trustees, board of directors, board chairs that see this as a priority and are willing to, invest in the personnel resources as well as other resources to try and improve the practice environment for clinicians.
Excellent. So, getting close to the end of the show here, what are some of the questions you think we may not have addressed? It has been a fascinating conversation, by the way. Thank you for your expertise in this space, and thank you for some of the insights that you've shared with us. Are there any questions or themes which you think we have not brought to the fore in our conversation here, which you think are important?
There's a few things that are on my mind that I think about, and I try not to spend a lot of time worrying or thinking about things I don't have control over, but I do worry about a few things. First of all, I worry about the influence of private equity, venture capital money, for profit in healthcare. And I understand it. It's not that I don't understand it. But it does trouble me at times, because I truly believe that our first concern should always be for the patients, families, and communities that we have a social contract with as physicians in society, to always put our patients first. And as a family physician, I always think of patients, families, communities, and doing the right thing from that standpoint. I worry that when private equity for profit is introduced, and not just within the physician healthcare, but also within insurance companies and others that are trying to make money out of healthcare, which again, I understand it. However, I worry that fiduciary responsibility is to the shareholder and to the return on investment, and that doesn't always align with doing the right things for patients. And so I worry at a system level, at a societal level, that the traditional healthcare values of patient first are continuing to be overshadowed by return on investment first, profit first. And so that worries me, because then I do think that sets a lot of physicians up to be in a position of moral injury when they know what's right to do for patients, but have pressures to do what's right from a financial standpoint. So I don't have an answer for that, but I do worry that that is one of the root causes right now of a few things. One of those being the erosion in public trust of physicians. I do a presentation for our medical students, and I share the Gallup poll numbers. And I've been proud to say, other than nurses always score higher than we do with trust from the public. Physicians have always been right up there at the top. Well, I'll tell you, over the last 3 to 5 years, physicians are taking a hit in the Gallup poll as far as public trust. And we're not down with used car salesmen or anything like that, but things are going in the wrong direction. And I truly believe that also impacts physician wellness, as feeling like, we've always been on the side of doing the right thing for patients, and that we've always gotten, the reciprocal of that is the patient level of trust. And I worry that patients feel like we as a profession are now making decisions based on what's better for us as physicians than we are based on what's best for patients and communities. And so I do think these are tied together as far as feeling a sense of fulfillment in your profession when you're faced with these moral dilemmas. So just something I have been stewing on for a while, and I worry that it's just continuing in the wrong direction. I don't know the answer to that one.
I'm glad and also thankful that you brought this up. We've actually discussed just in a couple episodes ahead of when this gets broadcasted, which I believe would be the first Monday of March, actually. Just a couple episodes, the season opener with Dr. Fry, who's a colleague of mine, a former interventional cardiologist, now a cardiologist at Ascension St. Vincent's. He is the former president of the American College of Cardiology. He and I had, candid conversations about private equity and how how it may have eroded or has started to erode some of the trust that our communities and our patients have in us as as physicians and as flag bearers of our health systems, someone at the forefront, because we are sort of a good analogy is first responders, in a health system. Certainly acute care physicians and, even our, primary care physicians, family medicine physicians who are, sort of the first point of contact for many patients. And so I share that worry with you. And I think, when you eloquently said that the fiduciary responsibility is to the shareholder, and those are competing interests. And when there's competition in interests, then there is erosion of trust. So there isn't a quick fix solution. It's a vexing topic. And I pray that it really does not erode, the oath we all took when we graduated from medical school. But I really appreciate you bringing that up. Thanks again. For everyone who's tuned in on a Monday to listen to another episode of Parallax. If you have any questions, comments, or feedback for Dr. Knight, do share them with us. You can email them to me or to the email that is shared on the show notes, and we'll make sure that we share that with him. We do take your feedback seriously, so do comment on any of the platforms that you tune in to listen to Parallax. And if you have any suggestions on guests you want to listen from, do share that with us, and we'll do our best to get them on the show. And once again, thanks again for tuning in and listening. And until other Monday, goodbye.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.